All right. So the first annual Plum lecture, how many people here know who Dr. Plum was? Okay, so very few people. So it's worthy that I start this introduction, tell you who Fred Plum is, for those of you who don't know. So Howard Riina, it's totally appropriate that he is the first Plum lecture because he is from New York, and he also started his career at New York Presbyterian Cornell. So this is our hospital. Okay, it was built. It was opened in 1931. It is on. I don't know if you know that when you walk across the street, you're on Profanity Hill. And the reason it was called Profanity Hill is because there were steps all the way down, the place where was burnt the other day, someone set it afire. That's called Profanity Hill. And it is right next to Skid Row, where the logs were cut and slid down to the Puget Sound to be taken around the country. So that's Skid Row. And of course, that's where they got that name because the drunks used to drink and slide down the hill. And now Skid Row, everybody thinks Skid Row's in New York or Skid Row's in LA. Skid Row's actually from Seattle, and that's where Harborview was built. Now, Fred Plum was the first chief of neurology. First chief of neurology at the University of Washington. Neurology was a division, not a department. And they got a 29-year-old guy to run neurology. He was an amazing guy. He grew up in New York. His parents were not wealthy. They lost all their money early during the Depression. And he was smart, and he got to go to medical school. And he really pioneered the understanding of consciousness in the pre-CT. Remember, CT, for all of you, the residents and sub-Is, CT was not available in our country commercially until 1970s, 1975, 1976, and MRI not till 86. So you had to do something called the physical exam, the neurologic exam. It's unbelievable. You had to touch the patient, examine them, talk to them. Mike, you still do that sometimes, don't you? But every day, right? So he defined the neurological exam. So think what happened. This is a gentleman that comes here at the age of 29. Dr. Williams, the chief of medicine here, was a brilliant guy, and he said, this guy has talent. He shows up here, and what is the disease of the day? It's polio. So there's a polio epidemic that breaks out in Alaska, and he goes up to Alaska with a bush pilot, and he goes, visits village after village, and he teaches them how to use the iron lung. That was the ventilator at the time. And what else did Fred Plum, when he showed up at Harborview, he starts a respiratory center because people are unconscious. They need to breathe. He either puts them in an iron lung and later a ventilator. This is him by the bedside. And the drug of the day was barbiturates. The overdose drug of the day was barbiturates. And he would go on and he would define persistent vegetative state and locked-in syndrome. He practiced at Harborview. He developed the first respiratory center, as I said, for the iron lung and then ventilators. He taught the neurologic exam to a generation of neurosurgeons and neurologists here. He developed hyperventilation as a treatment for high ICP. Randy's turning his nose up at that, okay? And he is in the original paper with Jeanette and Teasdale, who developed the Glasgow-Coma scale. He was their friend, they were his friend, and they helped develop the Glasgow-Coma scale. He was one of the first media neurologists in many ways because he's the one that said Richard Nixon should be able to choose the way he died. Richard Nixon had a stroke, and he chose the way he died. He didn't want to live in a vegetative state. And he often said that the practice of medicine is about preserving the brain. He's an amazing guy. And the one book that I still have from my medical school days is this, The Diagnosis and Treatment of Stupor and Coma. It's probably one of the most important books written in neurology in the modern era. It was written in 1966. His young student from the University of Washington, who went on to follow him to New York, where he became, Plum went on and became the chair of neurology at Cornell. He wrote this book, The Diagnosis and Treatment of Stupor and Coma. It's what we all use to learn how to examine the unconscious patient or the patient in stupor. How many of the faculty still have that book? And I will tell my residents and sub-Is, buy that book. It's in its 5th edition. It is worthy of your attention. Anyway, and he made the point that intervention in minutes can often make the difference between life and death for the patient. The examination is much faster and more accurate than any imaging study, he said later in his life. So, and Randy, that goes a little bit to your South American study where without CT scan, the exam directs what they do. So it is all together fitting that we have Howard Riina as our first Plum lecture. When I told Howard, his head snapped back because he spent the early years of his career at Cornell, where Dr. Plum went after the University of Washington and became a renowned chairman of neurology. And just for the neurosurgical residents in the room, this is the first chair of neurological surgery, Arthur Ward, legendary figure. First neurosurgeon was here in 47, and this is the first funded epilepsy center. All right. And we have Professor Kim to introduce you.
Thank you, Rich. It's my absolute pleasure to introduce one of my.
Who's going to
pick this? Okay.
Yeah.
Hold that.
I kept hearing myself talk. So
The speakers are on.
wow, what a picture.
All right. This is much better. It's my absolute honor and privilege to present as our guest visiting professor, grand round speaker today, Howard Riina. You're going to get to know Howard a little bit right now as I introduce him, because I've known him a really long time, over 25 years now. And we actually crossed paths in training at Barrow Neurological Institute many years ago. And even though it was only a year of his life, it has been a lifetime of benefit for me. And so I'm grateful for my friendship and my mentorship from Howard. There are a few things you don't know about Howard. First of all, he has a beautiful family, and he's one of the few people I know two neurosurgeons who have triplets, and Howard's one of them. And he had natural triplets, 3 girls, after having a girl first and had a girl after. So he has 5 daughters, and they're all out of the house now. I think this year is you're an empty nester this year. Sent last one to college, Tulane. And, he deserves this T-shirt. And the other thing is, when you have 5 children, obviously the house must be chaos all the time. And we all know as parents. And it's so much so that you actually even spell your name wrong on your Christmas card. I'm surprised I'm the first one to tell you that. And the other thing you should know about Howard is that we share this passion for old cars. And I hope I don't wish any of that on any of you. It's a terrible pastime, but it is a passion thing for us. And on the right is Howard's current Ferrari. It's a '67 Ferrari. It's in this various stages of restoration. The restoration cost of which is more than my car is worth, the one on the left. So I just hope that it pans out for you, Howard. We're pulling for you on that one, but. We are a product of our environment, and Howard's one of the rare people who not only benefits from his environment, but really actually elevates everyone around him. He started his training at Penn with Dr. Flam, who's a world-renowned vascular surgeon, and that really set the tone for his career, I think. Dr. Flam's not really nice to very many people, but he's extremely nice to Howard. I don't know why you have this Svengali on him or whatever. And his nickname was Flammable Flam, as many of you may know. And, I don't know if it's true, but famously punched a resident in the OR and all this sort of stuff. Those days are over, Rich. Can't do that anymore. And unbelievably, in 1996, I guess 96, 97, he went to spend time with this man, Alex Berenstein, who is, he and Dr. Hopkins are like the grandfathers of neurosurgical endovascular treatment. And he was a radiologist, of course. But this is way back. I mean, neuroendovascular was not even a field in 96. It was nascent. My fellowship director, Cameron McDougall, I don't know if Cameron's here. Oh yeah, there's Cameron. Cameron, I think you finished in like 98 or something like that. What year did you finish? 95. Okay, so right around the same time, and that was very early in the era. But it's emblematic of Howard, who's an innovator. He's a pioneer. He thinks way ahead in the future, and he knew that this was going to be the revolution in neurosurgery that it became. And then he and I both had the opportunity to spend time with this guy, Robert Spetzler, who really has remained a close friend and confidant of Howard's over the many years. But it's just, again, Howard was only there for a year, and he just makes such a huge impact on these people's lives. Not just, it's not a one-way street; it was a two-way kind of a thing, and they remain closest of friends even to this day. Then he went off, as Dr. Ellenbogen mentioned, to Cornell, where he spent time with Phil Stieg, the chair, and Pierre Gobin, who I had the pleasure of meeting. He's the guy who invented the Mercy stent retriever because he's French, and the Mercy stent retriever is like a corkscrew. So it makes sense that a French guy should invent a stent retriever that looks like a corkscrew. And then in 2011, he left to join Dr. Golfinos's department at NYU, and he's been there ever since. John actually trained at Barrow as well. And sort of the connections there with Barrow and NYU remain very strong. His partners there are Max Shapiro and Peter Kim Nelson on the left and right, respectively. And then, of course, Dr. Sen and Rajiv are there as well now. And I think Rajiv's probably going to stay on and be their junior faculty member. And we're really grateful for that connection. But really, I can't, and it's cliche to say this, but it's really true in Howard's case. I can't really, summarize all of his accomplishments in his life, but I'll do my best. As you saw on the first slide, he's the Lucius and Littauer Professor of Neurosurgery. He is the director for the Center of Stroke and Neurovascular Disease at NYU. He has taken on many leadership roles nationally and internationally, but they're always themed around service and the betterment of our specialty. For example, he's been the chair of the membership committee at the Senior Society. He's been on the editorial board of JNS. He's been a longstanding advisor to the Washington Committee, which is our political activist group. And he's also been on the committee for the double ANS and CNS endovascular committee. He served on the NESAC and the CSAC. Those of you who have RFPs or recognition of focused practice, like Melanie Walker and Mike Levitt, his signature is probably on your certificate, I bet. He's been part of the overhaul of improving and the quality of the training, the consistency of the training in our neuroendovascular subspecialty. He's currently the secretary and director of the ABNS. He has, which I've been fortunate enough to join him this past year, and really a great organization that Howard, being the secretary, is really our leader. We really look forward to a lot of the exciting changes in the board ahead. Academically, he has hundreds of peer-reviewed articles, dozens of grants as PI or co-PI, including AHA, NIH, NSF, and over 125 invited lectures and visiting professorships. As an innovator, he has 13 US PTO patents, mostly pertaining to endovascular devices. But I think most importantly, he has literally triple-digit numbers of mentees as students, residents, fellows, and faculty around the country like me. He has just very recently, taken on the extremely exciting role as Director of Clinical Innovation at NYU Langone. where he is basically transcended the neurosurgical department and is now really going to run a major division within NYU, which, as many of you know, is one of the most successful healthcare systems in our nation. And that's saying something this day and age. But, now for something really surreal. And I can't believe that this happened to me, Howard. But I was watching the Super Bowl one day. And this guy's face pops up on the screen while we're at, McGilvra's with Dr. Ferrera down watching the Super Bowl. And I thought I had like an LSD flashback event or something like that. But it was Howard. I texted him right away and I said, Howard, the camera really does add 10 pounds. And what he texted back, I can't repeat to you, but I thought it was good. And it's not every day you see one of your close friends on a Super Bowl commercial. Sorry, this is not supposed to be there. Get rid of that. And I just want to finish by saying, if I could describe Howard in 5 words or 5 phrases, I would say he's authentic, fiercely loyal, he's passionate, he's unflappable, and he's extremely loving. And I'm really blessed to have him in my career, in my life. And I'm happy to introduce, as the Plum Professorship, my mentor, friend, and big brother, Howard Riina.
That was really great. I think that's Graceland, right?
It is good memory.
Right.
Yeah.
All right. So I had added your slides in there, and I don't think this is. Oh, it is working. Good. So first of all, I'm honored to be here. It's always fun to come home to friends, and friends are very, very important. There, we're going to start. And all those things that they said, I don't know how true many of them are, but they're nice to hear. I had a professor when I went to graduate school at Cambridge 30 years ago, who basically said to me that he would help any student that wanted to help himself. And that was that stayed with me. And so whenever anybody comes to see me, I always try to find a way to help them. So I had 2 talks that I could have given. One was the innovation talk, because that's a thing that's on my mind with this new job that is going to take up 50% of my time, apparently. And the other was about aneurysms. And I chose aneurysms for a variety of reasons, Lou being one of them, but it's also an interest. And then we were at dinner last night and Melanie said, aneurysms, how boring. And so I was thinking about that last night. And, and there's a lot in that statement. You know what? Aneurysms are boring now. I mean, there's some big nasty ones and things like that we deal with, but aneurysms are boring. And you know what? And how great is that? Aneurysms used to be the bane of our existence. I remember being a junior resident at Penn, coming into the ICU, there'd be subarachnoid hemorrhage after, bed after bed after bed. And I remember the chief resident going, aneurysm gone bad, next door, aneurysm gone bad. All right, we don't see that anymore. Aneurysms do really, really well. In fact, we do aneurysms in 45 minutes. You go up through the wrist, boom. Aneurysms are boring. That's a triumph. That's an incredible triumph. So that's the only way I can respond to Melanie's thing. But in the beginning, God created vascular neurosurgery, open vascular neurosurgery. Okay. And so we try to get our kids out of the country pretty regularly. And it's important to get them out of the country for a variety of reasons. But you have to see some of the things that are in this planet. And obviously the Sistine Chapel and the ceiling of the Sistine Chapel. Now, we all know about the brain picture, part of this, right? Everyone knows that Michelangelo put the brain in the shape of God in his cape and everything, so that man was created by his brain. But the other important part of this picture is the hand, right? The fingers, right? What's important about the fingers? Adam is passive. His finger is bent. God is active. All right. You have to be engaged. You have to be active. All right. And that's the point of this discussion. And we're going to talk about when we're active, that's when we innovate, that's when we do things. So endovascular strategies, as Lou said, actually it was 1992. I was an undergraduate student at Penn in 85, and in 86, I had to do a senior design thesis. The chairman of bioengineering called me into his office and he said, there's two interventional body radiologists that want to put a stent in the abdominal aorta, and they want you to design it. And so I went over, and that was my senior design thesis. That was 86. The radiology department at Penn gave me a grant for $200,000, which if you think about it, in 1986, that was a hell of a lot of money. And I had a lab in the basement of an engineering building where I had grad students. But NYU called and asked me to move the grant to New York. So I came up to New York and I met Alex Berenstein, and that actually changed my life. But as you know, endovascular is amazing, right? So it starts with diagnostic angiography. These guys were in the 70s injecting celastic beads. When I started coming to visit Alex in the late 80s and then the early 90s, we had to sew balloons onto the tops of catheters and then knock them off into the aneurysm. So you'd bring the balloon up into the aneurysm, and then you'd knock the balloon off, and then they'd sort of bounce around inside there sometimes. And I'm sure Dr. Shaker has seen many of those cases, and a lot of those balloons went flying. We had detachable coils came in 91. That's kind of the beginning of the golden age of endovascular. That's when it all started. And that's when we started treating aneurysms more effectively. Jacques Murray in 96 did balloon remodeling. And then he started seeing specifically designed neurostents. We were taking coronary stents and bringing them up. But before that time, there wasn't a lot of stenting available. And that was really for wide neck aneurysms, and we were getting great results. And then in 2007, flow diversion happens. And flow diversion, I think, was another inflection point. Flow diversion really, really changed everything. And now you're in this sort of intrasaccular, but there's no reason why it's not going to keep going, right? So endovascular has really, really done amazing things. Why do we like flow diversion so much? Because it's different than some of the other things. Filling an aneurysm with coils is one thing, but a physiologic treatment is another. It addresses the vectors, right? The force vectors that cause the aneurysm to form. And so you've all seen this, where you put it through a dysmorphic segment of a vessel, and then you come back and look later, and the vessel's been remodeled. That's something very, very different that we haven't seen before. We're harnessing the body's ability to normalize itself by using the different forces and cellular structure. And so, as you know, aneurysm occlusion takes 3 to 6 months, and then it's this endothelialization that happens. Now, all the way at the end of the talk, I have a couple of slides where we can talk about this ischemic remodeling, which potentially would be something in the future that we can harness. That's when you cover vessels and we allow the collaterals to develop. But you're familiar with a lot of these things. So this is one of Kim Nelson's early cases from the PUF studies. You have to remember how transformative this stuff might have been. For you, this stuff is routine. You see these cases all the time. But again, when this first was being done, no one had seen anything like that. And if you had told someone that did open surgery that you could get from that to that, they never would have believed you. So endovascular gets kicked out of the Garden of Eden. Endovascular is asked to leave, right? I always do find it interesting that our caduceus looks a lot like the snake in the tree from the Garden of Eden. But so endovascular is asked to leave the Garden of Eden, but it goes on to develop on its own. And you know all these different types of things, all these different amazing dolichoectatic treatments where you can sort of remodel things and wind up with these unbelievable results. The other thing that was happening simultaneously, and Rich mentioned this in his introduction, is so when I started my internship, the CAT scanner came up 1 pixel at a time, not 1 page of the slice, 1 pixel, right? And I started my residency in 93. So this, it would come up, you'd have to wait, until it made the whole sheet, and then you'd have to get the other slice. I mean, it would take 20 minutes for the CT scan to come up. Forget about MR. I was a gadolinium test patient. All right, they tested gadolinium on me. I volunteered. I got paid $700. So I'm going to show a bunch of cases, and we can talk about them. They're all recent, so a lot of them don't have follow up, but you can get the gist. This is a 38-year-old female, headaches, no real serious family history, and she had a almost 8 millimeter ophthalmic aneurysm, superiorly pointing, daughter sac, all the things that we worry about. And again, this revolution in imaging was happening. We never had, I mean, obviously angiography had been around for a long time, but the three-dimensional angiography is just incredible, right? So you see the daughter sac, you don't like it. We would have operated on these. You'd have exposed the carotid in the neck and all these things. The operations would be 6 to 8 hours. We did all of that. And now you can go up there, you go through a radial approach, you drop your pipeline sort of bump down here, and you get flow diversion, right? You see it, there it is. There's the device against the wall, and you're seeing evidence of flow diversion. I can't stress how transformative that is, right? You're witnessing something that very rarely happens in medicine. Maybe we're going to see a lot more of it now with all the, the power of computing that's going to come with us. But to see these kinds of transformative events in a specialty while you've been, I mean, I kind of see myself as being there from the very, very early part, not the beginning, but pretty early. And now I'm watching it, come to this point. It's amazing in my career. So again, this is post and lateral, and she'll be followed up. This is just Jonah. I have nothing to say about Jonah other than he was swallowed by the whale and spit out. Next case is a pica aneurysm. 43-year-old male, acute throbbing headache, neck stiffness, history of smoking, and unusual type of aneurysm, probably a dissecting aneurysm. You can see it, get a good idea. Maybe you might want to coil it, but I don't know, it kind of looks like there's stuff going in and out. And then, of course, the 3D shows sort of this sort of no neck sort of blowout with lots of little bubbles and ugly. And obviously we used one of the Vantage stents, which can fit in there. And again, you see early evidence of flow diversion. And there's your, reconstruction at the end. Now, is this going to stay open? I don't know. I don't have the follow-up yet. The pica may close, and that gets into this idea of ischemic remodeling. The patient will either have a stroke or they won't. I don't think they will. They haven't yet, so it's either going to be open or they've developed a collateral and the vessel is closed. But the fact that we can go into the pica and drop a flow diverter is pretty amazing. We would have otherwise had to excise this and sew the two ends together, and we have friends that would do that pretty regularly and routinely. But again, it was under an hour procedure to do this, so it's worth a shot. That's a mosaic from a floor in Pompeii, so it's 2,500 years old. A lot of fish in the Bay of Naples, right? So flow disruption, right? The web device, right? We're going to use the web device. Intrasaccular placement, it's improved for intracranial wide neck bifurcation aneurysms. You know the whole story. But the important thing about it is that there's low morbidity and mortality. What's the difference between endovascular and open surgery? It's actually the way the patient tolerates the procedure, right? And so we were talking last night about one of the papers that took me a long time to get published at the beginning of my career was I wrote a paper of my hybrid experience. So it was from the first 5 years of my practice. I had 200 endovascular and 200 open cases. And it got vicious reviews, but eventually it got published in some obscure neurosurgical journal, not one of the major ones. But buried in that paper were basilar tip aneurysms, were a bunch of basilar tipped aneurysms. And all of those patients were alive and walking around, whereas some other colleagues of mine were talking about surgery for open aneurysms, open basilar tip aneurysm, and reporting 20% mortality rates. So maybe some of my basilars weren't completely closed, but they were alive. So I think alive trumps, 20% mortality. So these web devices have a low, low morbidity associated with them, and they're pretty easy to use. They have some issues with detachment, but you're going to see more and more of this intrasaccular technique. So here you have a 67-year-old female with some memory issues, ICA terminus aneurysm with a broad neck. You can see the aneurysm there. Again, lumpy and bumpy. We don't like that. Small ophthalmic aneurysm as well. And again, you can put these in and get very, very nice results in positioning. And what we've been doing with these is follow-up CTAs. I have fewer and fewer patients that want to come back for angio. I go, isn't there another way I can come in and just so the imaging is great. So we can sometimes we'll do a follow-up CTA for these intrasaccular devices. And you get really, really amazing pictures. So that was at 6 months, and they're not on aspirin or Plavix or anything like that. And as you know, these can do really well. This is a 71-year-old ACOM level aneurysm. And again, positioning these devices, once you get a good angle and you have the device in a good position, you can get a very, very good result. So the same thing, ACOM aneurysms, one of the aneurysms that I still like to try to operate on if I can with open surgery. Again, this patient has a big A1, it points right into the aneurysm. You can see the aneurysm. Again, another sort of irregular daughter sac. I'm always amazed that we don't see more of these subarachnoid, some of these ruptured, and come up and place the flow diverter in it. You see early evidence of flow diversion, which is always a good sign. And again, a follow-up on a CTA, and there should be a 3D in there. And that looks good. But we continue to follow them because one of the things that we see, one of the problems that we see with the intrasaccular devices is the devices can compress over time. So surgery. So what are we doing surgery on? Well, what do I operate on? And again, I always was amazed. This picture always bothered me, seeing the dome on the dome on the dome, right? So the tiny weak here, I'm always amazed that these things aren't just rupturing left and right. And so we use it for complex aneurysms where endovascular options aren't feasible. That's kind of a loaded statement because that's always changing. It's a moving target. The occlusion rates are extremely high, low rebleeding and recurrence. Obviously, older patients, posterior circulation aneurysms, you know the litany. They do better with endovascular, but young patients, they want to have an aneurysm fixed right away. They're doing other activities. They don't want to be on dual antiplatelet. So surgery is still a good option for them. So there's a 72-year-old gentleman with a transient neurological episode found to have a good size PCOM aneurysm off of a fetal PCA. And so thanks to you guys, we've written a paper on covering fetal PCAs with flow diversion, and actually we could do it routinely, but at this time we were sort of going back and forth at our shop, and so well, we can still offer surgery, and so that's kind of what we did. Let's see if we can get the video. Can I? There we go. So again, big nasty aneurysm. You can see the fetal PCA going off into the distance. I do have a pointer, right? The fetal PCA going off into the distance, and then just sort of putting the clip across that. I like to sort of go slow with the clip closure, especially with these sort of older vessels. You can see all the plaque in there. You don't want to break anything off, and just sort of closing it down with a clip slowly, and you get rid of the aneurysm that way. Not sure what else is on there. The other thing about this, and I'm not sure how you do it here, no retractors. I know Spetzer got around to that, but I think at the time we were still using retractors there, but I don't use any retractors. I push things out of the way with the sucker, that kind of thing. As you're familiar with, I don't think we put anything else in there, and that's just looking around to make sure everything's okay. Is that the same one? And then intraop angio, which we use all the time. A little bit of a nub in there that may or may not prove to be something, but we'll keep an eye on it. But at 72, doing quite well. This is a 58-year-old patient with a neck recurrence of a previous web device. So this is a guy, he's a giant guy. He was like 6'8", 350 pounds. And literally had no neck. His like there was like we were worried that I wasn't going to be able to position him on the operating table. He didn't want a craniotomy, and so I actually webbed this. Okay, so this was one of the earlier webs I did. It was a big, broad neck, nasty MCA aneurysm bifurcation. It took a while to get the device up into the area, and you can see the device. You can sort of see it there, sitting there. Looked pretty good. Looked really good, actually. We're kind of happy with it. And then we did that follow-up CTA. It looks good, right? It looks pretty good. Looks like it did the thing that we wanted to do. And it was gone. But we kept, and again, the 3D looks really good. And we kept following him. And lo and behold, last year it collapsed. And I'm not quite sure why, because it looked good and it was stable for a while. So it just shows you that you have to keep following all these things. We're trying all these new techniques, but again, you can see it's sort of pancake for some reason, and there's not a good explanation. So I figured that was significant recurrence that probably should have surgery. Fortunately, they developed these new drugs now that people can take, and he lost 150 pounds. Suddenly he can fit on the operating room table, so he had surgery, and there, I can control it here with that. I didn't know that. So again, this was so that you can see the web. It's right there. See it there? So there's not too much tissue. I didn't really want to open the dome, and you can see how the dome is sort of thinning out the temporal lobe there. And so again, I'm just trying to close it slowly, so I wasn't sure how the web was going to react to the clip blades, but you can see it's sort of collapsing slowly. And we're trying not to rupture the aneurysm or stuck with the thing. And it collapsed actually kind of nicely. That's a bit of the web coming right down into it. So we did the indocyanin gene green, and we put the papaverine on in the operating, all the things that you guys do at the same time, and it looks really good. It looks great. So we're able to do that. And so here you have a case of an endovascular failure or a web failure that was very, very suitable for surgical clip reconstruction, and that dealt with the problem. So one of the things that we started doing when I was at Cornell, we were doing eyebrow incisions for ACOM aneurysms. It just seemed like a natural thing to have a direct approach to it. And so I started doing them about 20 years ago, and I liked it a lot. And the only downside was that some people don't like having a scar on their face, especially over the eyebrow, depending if you have I have thick eyebrows, but some people don't. A man might think it looks kind of tough if you have a scar on your eyebrow. I have a scar on my nose right now. But the plastic surgeon, David Staffenberg, who I was working with, who's known for separating joint twins, said to me, goes, why don't we use the eyelid? Why don't we do a blepharoplasty incision? Use this incision because that doesn't scar. And you don't have to put an incision on the forehead. You don't get the numbness and things like that. There's literally no scar. And you can come out into the corner here and give them a little sort of crow's crease there kind of thing. And so that's what we started doing for a lot of the ACOM aneurysms that we wanted to do surgery on. The exposure is the same. The first time I did it, the aneurysm ruptured and I was kind of cursing myself. But then as you start moving the scope back and forth, you realize you're working in the same corridors that you would for a big full terreonal. Remember, the opening's only this big. It's kind of very, very small opening, but you get your instruments in there. You can't use a retractor here because the retractor will not fit in the thing, but they literally have no mark on their face, right? Pretty amazing, right? No change, no nothing. It's incredible. So there's that. something to consider. And so the best thing is to remember that all these things are tools. So we have all these endovascular tools. You have flow diversion, you have intrasaccular, the tech's going to keep changing. We still have tried and true surgery. Well, sometimes we do things together, right? So this originally was a patient who presented much earlier when they were younger, 21-year-old male with Perry-Romberg syndrome, right? Had a giant fusiform ICA aneurysm with a saccular component that was actually treated. It was an early pipeline case done down south. And the patient had blindness in the left eye after the procedure and severe visual loss on the other side. They had put more flow diverters in, so they had a multiple construct. The aneurysm continued to grow, eventually wound up in Phoenix, wound up having a bypass and a vessel occlusion, and then a follow-up study in 21 where the patient had a new now ACA aneurysm. And they were shopping around. After my procedure, the mom told me that she didn't like me when they met me the first time, which I thought was unusual, because I think I'm a nice person. But she said they didn't like me in the beginning because I was so like, I basically said, well, why would you have an open operation? I'd at least try to fix it endovascularly first, and if we couldn't, then you could always go back. But you'll see here, so these are the original pictures from the original treatment down south when he was very young. And that's the one with the visual loss. Initially, it looked very good, right? So it looks pretty good. But then on follow-up, it continues to grow, right? So the aneurysm continues to fill. And so the aneurysm isn't treated. This is how it winds up when they wind up in Phoenix to see Dr. Spetzler. Here's the MRA image. And so Spetz puts a clip on and he does the bypass. And when I meet him, this is what he has. So he's got this now dilatation of the ACA and this big ballooning. People are saying go in and do an operation, do surgery. The ballooning kind of ends and comes down to the level of the old construct. And he's got a bypass that's not completely working for some reason. And so when the bypass doesn't work, there's not enough demand on it, right? And so here's the bypass, not really doing his thing. The guy gets headaches, especially when he has like hypotension and things like that. So maybe even some ischemia, and he's got a good bypass. It's, Dr. Spetzer does a good bypass. So here you can see his construct, you can see his bypass. So what we decided to do was, and again, here's from the posterior circulation through the PCOM. So he's got some natural collateralization. He's formed this big aneurysm from the contralateral anterior circulation going across the ACOM, but that vessel is abnormal. And he's got a carotid occlusion in the neck and an inadequate bypass. So it sounds pretty complex, but the solution really wasn't. So I decided to take a microcatheter, go up over the other side. I guess this is kind of why the mom said she thought I was being flippant. I said, I just wanted to see. I wanted to understand. So it came up, I came across, I went into that aneurysm and then down. And I was looking for perforators because I didn't want to just sort of knock off the A1 in case he had something coming off that area. And things were looking pretty good. I came in there and I said, you know what, I'm just going to take this thing back. And so that's what we did. We sort of coiled it back and already that thing wanted to close. And so, and then you could see we sort of coiled right down onto the old flow diverter. You can see the bubble sort of with almost like flow diversion, stagnation in there. And that seemed to deal with the aneurysm. And then lo and behold, bypass started working, right? So we got rid of that sort of collateral that was preventing the bypass from doing its job from the anterior circulation that caused the aneurysm to form in the first place. And then from the posterior circulation, again, it was also getting plenty of flow. So I think we got it. And we actually, I convinced Robert that we should publish it because I thought it was a good example of using all these different techniques to tackle a very, very complex problem. So that's NYU now. And now I could stop here or I have a few more slides on this ischemic collateralization. I'm okay, right? So I just want to put that in there. You guys know who that is? Any of you know who that is? Oh my God. Anybody?
Sinatra.
All right, good. That's Frank Sinatra. I know you would know Sinatra. That's Sinatra in 1940. Okay, so you'll think that Taylor Swift, with the Billions and Swifties and all that, My Daughters and all that, and then the Beatles with the Billions and all that. But before that, there was Sinatra. This guy he was like the modern he was the Swiftie of his day. We don't know that. Anyway, ischemic remodeling. This is a patient that had a subarachnoid hemorrhage, and repeated coilings of this sort of complex acomic aneurysm. And so he had been coiled, retreated several times when he came to see me. The initial idea was to operate on him. He was kind of resisting surgery. Most of the people that he saw had told him to have surgery, just clip it and be done with it. And I said, the only thing that I could think of doing endovascularly was to come from ipsilateral A1 to contralateral A2 with the flow diverter and jail the ipsilateral A2, okay? And I kind of convinced him to do that. And so we did that at first. And I was a little nervous about it because, again, jailing large vessels, it's kind of nerve-wracking a little bit, but now we're sort of learning that you can jail them. And this was a good case that you could. But when we followed up with it, right? So here's the contralateral going, but you see we're not seeing anything there. But what is he doing from the posterior circulation? He fills the territory, right? And he developed that over time. So that's kind of ischemic remodeling. That's sort of stimulating the system to ramp up the collaterals. Now that's something hopefully that maybe we can learn how to harness that in the future for moya patients or patients that are having stroke where we can't do things. The beauty of the flow diverter idea is it takes time to work. It takes time for the flow diverter to get covered with endothelium. And in that slow process, it causes the ischemic demand, the tissue thromboplastin release, the angiogenic response. And remember, the angiogenic response is different than moya, right? So in moya, you get ischemic collateralization that results in friable vessels that can bleed. These are real collaterals that are ramped up. And so it's a very, very different type of thing, right? So the neovascularity that you see in a moya-like condition where there's an underlying pathological process involving the lumen of the vessel or the tissue makeup is very, very different than what we're seeing in this sort of forced ischemic collateralization. So it's just an idea that I think is worth consideration. This is much of the ceiling of the Sistine Chapel. So that's our team now. Maybe we're going to be adding few more people here, and I'm happy to take any questions.
Anybody? Howard, your team, you and your team are also kind of pioneered telescoping stenting for certain situations. Where do you see that? Where's the sweet spot? Where are the limits of that?
Telescoping for, you mean VB junction or for just everybody? Yeah, so there is a underlying I don't want to say it was a rule, but in the beginning, we definitely would put 2 or 3 pipes within pipes. We thought that it would close the aneurysms more quickly and that it gave some protection. Remember, in the original pipeline period, it wasn't part of the PUFS data of Cameron, right? The 12 ruptured patients in the first year, like there were 12 patients that died in the first year across the globe. And there was a little bit of concern that we were piping these big aneurysms, there was thrombosis, and then the wall of the aneurysm was breaking down and the aneurysms were rupturing. That was and people were very, very nervous about it. And so that's when the idea of coiling with the pipe sort of came in for large aneurysms. The theory was that symptomatic aneurysms were unstable, and that was an issue. I think that's where the idea came from. So Kim wanted us to put 2 or 3 in there because we thought it gave some kind of protection. That's where it came from. I think we've kind of backed off it a little bit, but you definitely get quicker. We published on it. You definitely get a quicker resolution and closure. So, you know, at a year, sometimes you have some people that are open and you wind up going back and putting another one. We were putting them in up front. Saru in Turkey will he'll accept the not closed aneurysm and say that it's treated. So I don't know where the answer is, but yes, we did do that. So the only thing I'll add to today is, so the other part of the, you know, UW actually had one of the early NIR endovascular. Joe Eskridge was here. Joe's not here today, is he? So Joe, so when I came up to Berenstein in 88, Joe might have been a fellow. I met Joe Eskridge, and Joe was here. And I wrote one of my first publications was with Joe. Alex put me on book chapters with him and stuff like that. But you had very, very early neuro IR, very, very well trained from day one.
And also for dilate, he wrote, I think Cameron would know better, but wrote one of the original papers on dilatation of the vessels after vasospasm, right?
Yeah.
He ran it, he should publish in the same journal.
Yeah.
Same time, that was the first thing about him.
Yeah.
And for those who don't know, that's Cameron McDougall, is one of the pioneers of endovascular neurosurgery, coming over from across the street. Thank you, Cameron. Here.
Yeah. Anyway,
you
so
very
so
much.
it was boring, but aneurysms are boring. That's a good.